Thank you.
Good morning, everyone. My name is Devin Diabate, and I am a global technical trainer for laboratory diagnostics at Siemens Healthineers. I'm also honored to serve as the national chair for the Siemens Healthineers Employees of African Descent. Today, we are so excited to share our partnership with Boston Scientific and support Black Health Matters to close the gap and bring health and wellness in the time of COVID-19. As a microbiologist, it is my pleasure to introduce Dr. Catherine Soring. Dr. Soring has a strong track record of working with highly contagious pathogens. She has a PhD in immunology from Emory University and completed her postdoc at the Center for Disease Control in Atlanta. Currently, Dr. Soring has global clinical education for laboratory diagnostics at Siemens Healthineers. Today, she will be leading our session entitled COVID-19, Why Vaccinate? Without further ado, Dr. Catherine Soring. Doctor?
Well, thank you, Devin, and I am so excited to be here. I'm hoping everyone can see my slides. I'm kicking things off here, and I'm really excited because I have such positive news to deliver on why vaccinate. So I am a scientist, as Devin said, so I'm going to use science to help us answer these questions in about 25 minutes. So what is SARS-CoV-2, severe acute respiratory syndrome, coronavirus 2, and how does it cause COVID-19, which is the disease that the virus causes? And what about the people that think I'm young and I'm healthy? My friends got it, it was no big deal. Why should I worry about infection? And then, of course, how are the vaccines currently used in the US designed? Are they the same? Are they different? And very importantly, what are neutralizing antibodies? And how can they help protect from infection, including with these variants I'm hearing about? And of course, the vaccine. Should I be concerned about the risks? Should I get it? And if I've had COVID-19, do I even need a vaccine? So lots of info to cover. Let's jump in. Let's start with the background of the coronavirus. Now, there are actually dozens of coronaviruses that have been identified. They principally infect animals, so we call them zoonotic. In terms of mammals, both alpha and beta coronaviruses can mutate and spread amongst different mammals. There's also gamma and delta that can infect birds as well. So lots of coronaviruses. For the most part, they stick with the animals. But for many decades, we've actually had 4 coronaviruses, 2 alpha and 2 beta, that mutated enough to infect humans. So you can see those 4 listed here. They're seasonal. They cause common cold-like symptoms. They never were serious, so we knew they existed. We weren't really worried about them pathogenically or medically. But then, of course, that all changed in 2003. In China, we first heard of this SARS-CoV, so the first SARS-CoV. And it turned out that was a virus that probably started in a bat, but it mutated to where it could infect a mammal over in China called a civet, which is sometimes used as a food source. And people that were exposed to the civet could actually get the infection and could be very serious. Some of them died, but very fortunately, the first SARS-CoV did not transmit easily human to human. So once we understood the risk, we were able to take measures and eradicate that virus. Then fast forward to 2012 and yet another coronavirus, also a beta coronavirus called the Middle East Respiratory Syndrome. Also probably started in a bat, mutated to where it could infect camels, and people in contact with the camels could become infected. So the same story, this was even more pathogenic, but fortunately did not efficiently transmit human to human, so we were able to pretty much control the infection. But then, of course, in 2019, we get this second coronavirus, severe acute respiratory syndrome, probably started in a bat. It mutated enough to where it could probably infect some other animal. We don't really know what that might be, but it really doesn't matter because this variant was one that could very efficiently transmit human to human. And because it was so good at passing from human to human, it resulted in the pandemic that we're now dealing with. So that's the background. This is principally a respiratory virus. So there, as we'll learn, there are receptors for the virus all through our body, including in the nose and mouth, and certainly in the lungs, particularly in the lower lungs, which is a bad thing, as we'll talk about in a minute. And so this virus uses human cells that it infects to replicate. It can't replicate by itself. So if it can't get inside the cell, it cannot reproduce. We'll talk about how the vaccines help our body accomplish that. But if you are infected, you are actually producing millions of virus typically during your infectious period. And when you talk or sing or sneeze, we all know that we, you know, emit these respiratory droplets. Sometimes can see them in the sunlight when you're driving in the car sometimes. And if you're infected, these droplets, they vary in size. They can be very small, where they can remain suspended in the air, or they can be quite large, where they can travel and then they quickly drop to a surface. But the problem is when you're infected, these droplets can have hundreds, thousands, even millions of infectious virus in them. So if you get these large droplets that settle on surfaces, you can actually contaminate your hand. And then, if you rub your face or mouth or nose, then you can get the infection that way. Certainly, this aerosolized virus is a problem because we do know that it can very easily, it's invisible, it can easily pass person to person. It can even travel through some air ducts. So the potential when someone is infectious to transmit is enormous because literally every time they're breathing, they potentially are emitting infectious virus. And one of the big problems, the challenges we've had with COVID-19 is that the majority of people, it appears from data, that they're asymptomatic. So they were actually infected, they are infectious, they have transmitted infection, but they didn't necessarily have any symptoms. Now, someone they gave the virus to could be very symptomatic, could get quite ill, or could even die. And unfortunately, we've seen this in families and friends where they didn't know they were infected. They got together in their little, group of friends or family. They thought they were safe, but we have one person who's infected who could infect multiple people who were in attendance. So you may have heard early on the church choir, there was one person, just two meetings of the church choir, that one person infected three-fourths of the entire choir. This can be very infectious and you don't even know you have it. In fact, my colleague, Dr. Arroyo, is going to talk shortly about testing and how we can help pick up those asymptomatic infections and control the spread. But for now, I'm going to move on to the misperception, really, that I'm young and I'm healthy. I really don't need to worry about the virus. So here's the data from the CDC. Now, maybe in your close circle of friends or family, you have known people that were infected and they didn't really get sick. They didn't need to be hospitalized and they were fine. But when you start looking at larger numbers of people, which is what the CDC has done, and you compare the need to be hospitalized from COVID or that you might die from COVID to what we call the reference group. And the reference group are people, children, 5 to 17 years old. Not that these children can't get COVID, they certainly can, and a small percent can get very sick and may even die. But the incidence is the lowest in that group. So it's the reference group. So if you start looking at 18 to 29-year-olds that are healthy, young, yet if you get COVID-19, you're 6 times more likely than that younger group to need to be hospitalized, 10 times more likely to die. And these aren't people with, comorbidities that are sick. We're seeing this also in very apparently healthy young people. Let's jump to 30 to 39 years old, still very young. And yet you're 10 times more likely to be hospitalized, 40 times more likely to die. And you can see as you get older and older, the odds just get worse and worse. So this is why early in the pandemic, we saw more hospitalizations in people that were older and certainly with comorbidities. But that misperception that you can't get sick or die is a very dangerous one. And this type of data helps reinforce the need to practice those precautions that the CDC talks about. Now, we think of it severe acute respiratory syndrome, but it's really far more than just respiratory, and we're still learning so much about this virus. But if you think about normal lungs, the X ray passes right through, and so you get this nice black space. That's where all the air you breathe in can go, get to the heart, and the heart can distribute it via the blood to your body. So that's a nice, healthy pair of lungs. What we often see in COVID 19 is this bilateral pneumonia. So the X-rays are being diffracted by fluid or sometimes cells. If it's bacterial pneumonia, which can be secondary to COVID, it may be bacteria. But bottom line is it's taken up all this space in your lungs. So that the air comes in, there's really nowhere for it to go. You can't breathe in enough air. You get short of breath. Eventually, you can't oxygenate and you may need to be put on a respirator. So, this itself can be very dangerous. And it was one of the first things we noticed with COVID-19. But then we found out other things. I believe later in the day, you'll be hearing about the likelihood of stroke and blood clotting issues with COVID-19 that are often linked to what we call the cytokine storm. So even if you don't develop the respiratory distress, you very easily could stroke or have some other very serious repercussion from the infection. And we also know while typically the virus starts out in the lungs, it can spread to other parts of the body. And the receptor, which we'll talk about, that the virus uses to get into human cells, is expressed on multiple tissue types. And we're just learning the type of damage that it can cause to the heart, certainly acute renal injury. My colleague, Dr. Royal, will talk about the fact that you can have a lot of bacteria being shed from your intestinal tract, not bacteria, I'm sorry, virus, from your intestinal tract. And actually, sometimes they're testing sewage to look for that virus as kind of a precursor to do we have an outbreak that's pending. So you'll hear more on that shortly. But bottom line is we have much to learn about this virus, but it is far more than a respiratory virus. And of course, the other thing is this growing evidence of perhaps about 10% of infections producing long COVID, or sometimes you hear the long haulers. And this is something we really don't understand, but a number of clinics are popping up all over the US because more and more people are showing up. And these are not people that were very seriously ill, typically, not people that were very seriously ill and hospitalized and on respirators. We're saying almost the majority of people had mild or moderate symptoms. So maybe they lost their smell or taste, and it just hasn't come back. We see a lot of people with shortness of breath, fatigue, mental fog, just all of these problems you see listed here. But it can be very debilitating. We have a 40-some-year-old, previously completely healthy marathon runner. She's over a year out now, and she still has severe shortness of breath and fatigue. It is a challenge for her to get up and walk to her mailbox. And that is not, that it's actually a true story. And if you ask anyone in these clinics, it's really terrible what these people are suffering. And no one can say, oh, it's going to get better, just give it time. Maybe it will, and maybe it won't. So long COVID, we have much to learn about. So let's talk about the virus a little more and how it actually causes infection in all these different cell types in the human body. So this virus has envelope. So this is kind of this lipid protective coat, and inside of it, it has its genetic material, which is RNA. Dr. Royal will talk more about that. And then it makes different proteins, and a really important protein is actually studded into that membrane, and it sticks out from the membrane. It's called the spike protein. And spike protein is really important because this is how the virus recognizes a human cell. And multiple human cells in our body, including our nose, our mouth, our lungs, they express this protein called ACE2. And ACE2 is actually the receptor for the virus. So if the virus gets in, it finds these cells with the ACE2 receptor, it binds to those, it enters the human cell, and it uses the cellular machinery to make copies of itself. Because remember, a virus can't replicate all by itself. It's got to steal our cellular machinery. And when it does that, these viruses then go out and they go on and infect other cells, and you can literally get millions, hundreds of millions of virus in your body during an infection. So, of course, the best way to stop the infection is to stop that virus from entering the cell. And the best way to do that is to block its ability to bind to its receptor. And this is exactly what the vaccines are designed to do. And they do that by using an element of your immune system called a B cell. Now, the vaccines will stimulate multiple parts of your immune system, but it turns out these B cells are really important because B cells make antibody. And antibody is a secreted protein. And you can actually make antibody to all different parts of the virus. But a subset of those antibodies are what we call neutralizing antibody. And we call it neutralizing because it can literally neutralize or block the ability of the virus to establish an infection. And it does that by binding to that spike protein, particularly to the part that attaches directly to the ACE2, which is called the receptor binding domain, or RBD. So if you have a virus that's coated with these antibodies, now all of a sudden, it can't bind to its ACE2 receptor, and you can block the ability of the virus or much of the virus to infect the host cell, and you can stop the infection in its tracks. And that's exactly what the vaccines were designed to do, to stimulate high levels of this neutralizing antibody, as well as other elements of the T cell and the immune system. Now, really importantly, we'll talk about this. Vaccines used in the US only use the spike protein. Remember, there are multiple proteins and parts of this virus. They only use one tiny piece of it, just that spike protein, to stimulate the body to make these neutralizing antibodies, which go on to be protective if you're exposed to the virus. So you cannot get COVID-19 from the vaccine. I hear this misinformation all too frequently. There's no basis in fact for that, because only using a tiny piece of the virus to vaccinate. Now, we were remarkably surprised at how well the vaccine worked. This is data from the Pfizer vaccine, which is an mRNA vaccine. I'll talk more about that very shortly. Also, the Moderna is an mRNA vaccine. And here's what they did. In their phase 3 trials, they divided two groups of people, 22,000 people each. They were either given the vaccine or they were given a placebo, so like a saline, but no one knew who got what. Then they were sent back out in the world where there was a lot of infection, and they followed these people up for several weeks to see who got symptomatic COVID infection. And what they found was really quite stunning, was that if you had both doses of the Pfizer vaccine, there were only 8 cases of COVID in that whole group of people, and only one of those was severe. If you looked at the placebo group, 162 cases, and 9 of those were severe. So when you do the math on that, we say the efficacy is 95%. That means that yes, you still can get infected, but really important, you're very unlikely to need to be hospitalized or to die. And I do apologize. It seems the lawn guys decided to show up with this mower right now. So I hope you can't hear all that in the background. So really good data from the phase 3 trials. But what they found was it was really important to get both doses of vaccine, and that is principally to boost up that level of neutralizing antibody. And we'll see that with time, antibodies, including our neutralizing antibodies, will decline. So now you hear Dr. Fauci and others talking about a potential boost. And it's no big deal. It's just yet another vaccine to boost up that level of neutralizing antibody, because that's very important, especially when we talk about the variants, because it may take more antibody to actually protect from the variants. All right, now this is a bit of an eye chart, so don't try and read it, but these are all the different vaccines that are currently being used across the world. Now, inside the US, we only have 3 that currently have emergency use authorization from the FDA. 2 of those are the mRNA, the Moderna and the Pfizer, and one is the Johnson & Johnson. It's a little different. It's what we call an adenoviral vector vaccine, but all of them rely on that spike protein to produce the antibody, the neutralizing antibody response. So when we look at how they do that, on the left-hand side, these are examples of the mRNA vaccines. mRNA actually stands for messenger RNA, and it is essentially a blueprint that tells the body what protein to make. So in this case, they put in mRNA in the vaccine. That's a blueprint for that spike protein, the whole spike protein. And they put it in these nanolipids so it's nice and stable, and you inject that, and then these lipids fuse with your cells that deliver that mRNA, and your body translates that to the spike protein, and that makes the neutralizing antibodies, right? So that's how those work. Now, the Johnson & Johnson vaccine is very similar. It does have this adenoviral vector, and adenoviruses are viruses that can infect us or not, severe viruses. And in this case, it's actually been inactivated, so you don't get any adenoviral replication. But encoded in the DNA here is, again, the DNA for that spike protein. So this gets in via the vaccine. The DNA is made into RNA. The RNA is made into the protein, and that stimulates those neutralizing antibodies. So 2 different ways of getting that spike protein in, but in the end result is the same. You get neutralizing antibodies as well as other elements of cellular immunity. Now, how long do those antibodies last? Well, each one of these different colors is someone who was vaccinated. And notice 2 things, regardless of the age group, the vaccine works well across the ages. You can see you don't get a lot of antibodies in a lot of people with that first dose. But by the time you give the second dose, you can see the huge increase in the level of antibody. Now, it does decline with time, and it may get to the point where you need to have an additional boost to boost up the level of antibody. We don't know right now what level might be protective, so we can't tell you that, at least not yet. But we do know the data is growing that high levels of antibodies really are probably pretty important to have maximal protection. But what about the side effects? Well, this is data from the CDC on the side effects for the Johnson & Johnson vaccine, and you are very likely to get side effects, but they're going to be mild. Pain at the site of injection for a couple of days, maybe a low-grade fever. In fact, fatigue, pain, and headache were the most commonly reported reactions, and typically they resolve in most people within a day or two. There can be serious reactions, so it's important to talk about those. And when we first started with the mRNA vaccines, we noticed that about 3 to 5 people out of every million that were being vaccinated developed anaphylaxis. And anaphylaxis is an immediate hypersensitivity reaction that can cause your throat to swell up or you can get the hives. It can be very serious, but fortunately, it's readily treated with epinephrine. So, this is why you have to wait 15 to 30 minutes in case you're in that small group that is prone to anaphylaxis with these vaccines. To a lower degree, it's also been reported with the Johnson & Johnson vaccine, the anaphylaxis. But again, very treatable, but make sure you stick around like they say you should. And if you have a history of anaphylaxis, particularly to a vaccine or any of the components, do check with your healthcare provider in terms of your risk benefit for getting the vaccine. And of course, more recently, we've had these reports of the blood clots associated with the Johnson & Johnson vaccine. I will tell you there's a similar adenoviral vaccine used outside the US made by AstraZeneca. We also have reports of blood clotting with that particular vaccine as well, but it is not approved for use here in the US, but the J&J vaccine is. So the advantage to this vaccine is only takes one shot, at least right now. You don't have to go for that, second shot. So a lot of people like that. But you do need to be very vigilant for any of these, one or more of these side effects, or not side effects, symptoms that could indicate that you could be developing a blood clot or have bleeding, low platelets, and you need to go to the hospital and make sure that you avail yourself of treatment. There are treatments. I do believe now that 3 people have actually died from this out of 9 million that have been injected. So it can be serious, but if you can get to the hospital, typically it can be managed. Now, if we look at data on the CDC in terms of these serious side effects and the doses, at the end of April, they issued this report when there were 8 million doses of the J&J vaccine. Now, there were over 13,000 reported events, but again, 97% of those were not serious. They were the mild to moderate side effects. 3% were serious, and they fell into that clotting group or the anaphylaxis. And at the end of April, they had 17 events associated with the J&J vaccine. Now they had a higher reports of anaphylaxis, but we also know that they can get very nervous and agitated sometimes getting the vaccine, and they can develop, shortness of breath, their breathing not too shallow. And so it looks like anaphylaxis, but it's not. So actually there were only 4 cases confirmed of anaphylaxis. But these clotting, continue to be a concern, although at a low frequency. So in the May 12th update, we're now up to 28 people that have experienced clotting events following J&J. It's not all women, preponderance of women, but 6 men, as well as 22 women. Now we're up to 9 million doses of the J&J vaccine. So if you do that math, the risk of having some type of clotting event or bleeding event is about 1 in over 300,000. Now, you don't like to have any risk whatsoever. You want it to be 0. But if you think about it, we face risk all the time. So do we think about when we get on our car to go to the grocery store that we have a 1 in just over 100 chance of being in a car accident, in which we may die? Well, I don't. I don't think most people do. When we go to the park or go to our friends, do we think about the chance that, there's a 1 in 86,000 chance we may be attacked by a dog? Same thing was struck by lightning. So there is risk to almost everything we do. And it really is a matter of the risk to benefit ratio. And this is certainly true with COVID-19 and the vaccine, because we talked about, how dangerous this infection can be and that you may infect others that you care about that end up getting quite sick. the potential to create more variants. There's a lot of risk if you don't vaccinate. Now, if you do get the vaccine, there is a very low risk of a severe adverse event. Those are carefully being monitored for and that data accumulating, but there's huge benefit. So I want to talk now about the benefit, at least in countries fortunate enough to have available vaccines. Israel was one of the earliest countries. It heavily vaccinated its population with the Pfizer vaccine. And this gold bar are people that are not vaccinated. These are symptomatic infections. The dotted line are asymptomatic infections. So they were routinely testing these vaccinated versus unvaccinated healthcare workers. And so they did uncover a number of infections that had no symptoms whatsoever. So notice how the frequency of SARS-CoV-2 infection is extraordinarily high when you compare it to the vaccinated group, or what we call cohort. So all these healthcare workers that were fully vaccinated, yes, there was a low incidence, about 1% of what we call breakthrough infection, but nobody got really sick, nobody died. And look at that compared to how many people were getting infected when they weren't vaccinated. Now, don't try and read all this data. This is data from a small country in the Middle East called Qatar. They also were using the mRNA vaccine, I believe the Pfizer. And I want to point out two things. One is that probably hard to read here, but highly circulating in Qatar at the time was the B.1.1.7 variant, the one first identified in the UK. It's the dominant variant here in the US now. It's one of the ones we're a little concerned about. And also the B.1.351, which has been referred to as the South African variant. This is a little more dangerous, and it was first identified in South Africa, also present in the US. So with these variants, you could see that the vaccine still performs extremely well to keep people from getting really sick, needing to be hospitalized, or certainly to die. But it depends on whether you get both doses. So in people that just had the one dose, they were only about 40% protected from needing to be hospitalized or dying. But 2 weeks after they got their second dose, only 3% of people, 3% developed severe or fatal disease. And you probably can't see the numbers here, but when you compare the vaccinated people compared to infections in the unvaccinated, it's huge. So 50 compared to over 16,000, for example. So really we can see in real world evidence, even with the variants, the vaccines are performing extremely well. Similar data in the US, I think we all know that we feel like we've turned a corner. We're definitely heading in the right direction, but it really depends so much on people continuing to get vaccinated if you're not. And if you look at data from the Cleveland Clinic here, when the vaccine was available, January to April, among the 4,300 hospital admissions for COVID-19, 99% of them were either unvaccinated or not fully vaccinated. So that really shows just how effective these vaccines are. But you might say, look, I don't like any risk of the vaccine. I'm just going to mask up until this thing is over. Why is that a bad idea? Because every unprotected person is an opportunity for the virus to infect, to take advantage of mutations that naturally occur that make it resistant to the vaccine. And we already know that some of the variants are partially vaccine resistant, not completely, especially if you have high levels of neutralizing antibody. But it really just put potentially a couple of mutations away from making these vaccines not work at all. And we don't know if that will happen, but the risk is there. So every vaccinated person is another barrier to allowing that virus to replicate. And that's really why vaccination plus infection control continues to be the best approach. And lastly, I know this looks a little confusing, so let me walk you through it, but it answers the question, and there's abundant data to support this, that says if you've had COVID-19, you still need to be fully vaccinated. And that's what the CDC will tell you, and here is why. So if you look at people that were not infected, you look at their anti-spike antibody level that I talked about earlier, you can see those that were not infected don't have spike antibody, okay? If you give them a dose of the vaccine, you see some people, make a decent level of antibody, others maybe a little lower. There's a range of a response, but certainly there's detectable antibody. If you compare that level of antibody to levels we see in people that actually had COVID-19, so that's here, these are people that had COVID-19. So some of them made high antibodies, some lower, some some really terrible, really no antibody response. So you get this range, but on average, it's equivalent to what we see with one shot of the vaccine. But if you take this same group of people and you give them the vaccine, these are the same people here. Look at how high their antibodies go. And in fact, what they found was people who had a natural infection were overall not very good at being able to neutralize the variants, but especially that South African variant, which is one of the more scary ones. But if you gave these same people one dose of the vaccine, they could very effectively neutralize those variants. So lots of good data for the ability of the antibody to be a key component of immunity and the ability of the vaccines to induce that antibody. And one other little bit of information going back to the long COVID, these are what we call anecdotal reports at this time. It means it has not been scientifically established, but we are hearing about 50% of people with symptoms of this long COVID, when they get the vaccine, they feel better or their symptoms fully resolve. Now, a small percent said their symptoms got worse, but there's an active study looking into this to see if long COVID potentially could be managed in part with the vaccination. So that brings me to the end of my presentation. I think I'm a little bit over time, so I'm going to stop here, but hopefully I've been able to address the questions that we started with. And I don't know, Devin, if we have time to take any questions or if I just hand it off to my colleague, Dr. Arroyo.
I will. Thank you so much, Dr. Soring. We do have some questions in the Q&A, so I'm not entirely sure if the host wants us to take a question or do we move on to the next session?
Could we get our host, IT, to respond to that? Is Dr. Arroyo queued up?
You know, think I think we have a moment. So do you want to ask one more question? I mean, would you mind answering a question?
Oh, no, of course. I'd love to answer all of them, but
Sure, sure.
I'm
So just looking at the time. So in the Q&A, there you go. In the Q&A, there were some people who really liked the risk and to benefit ratio
oh,
and
good.
would love to see that slide again. And there was another question, and let's see. Do you think, so I think you kind of answered this, but maybe you can add to it again. Do you think that any of the antibodies produced in response to COVID-19 might cross-react with antibodies produced for other coronaviruses that infect humans?
Yes, that has been a subject, especially early on, of significant investigation. So those common cold coronaviruses that I talked about, there was some little bit of hints that maybe some of those antibodies to those could be protective. And so it could go the other way too. Could these antibodies protect from those? Overall, though, I think the data is the viruses are enough different that you're probably not going to likely to get a lot of cross protection.
Gotcha. Thank you. And there was another question about what implications does this have for understanding the results of antibody tests against the future of the disease? So if I have antibodies, does that mean I'm immune to future infection?
So that's the whole point of the trials. And if you remember in the Pfizer data I showed you, even though those people were vaccinated, about 5% of them developed symptomatic COVID. And we know from more newer data that a lot of people actually have asymptomatic infection, even when they are vaccinated. But what we see with the vaccine is very clear. Number one, those antibodies and other aspects of your immune system help drive down the viral load. They inhibit the ability of that virus to replicate, and that makes you less infectious, which is a good thing. So you're going to lower transmission even if you get infected after you've been vaccinated. And very clearly, the vast majority of people are not going to have to be hospitalized and they're not going to die from COVID. They may get ill and they may be potentially infectious, but they are not going to die in all likelihood. And that's really the clear data coming out of the vaccine trials. You can still get it, but it will be a very low frequency.
Yes, that was definitely something that was striking to me as well, just about that long COVID that you had talked about, and reducing those long-term effects.
Well, I want to be clear on that. The long COVID is
Mhm,
not a perpetuation of the viral infection that we know of anyway. We
mhm,
don't really know what causes long COVID.
mm,
It's really just based on the symptomatology at this point, we don't even really know how to manage it. There's a lot of work, and hopefully we'll figure out and be able to treat it. But it's not that the virus just, you can get rid of the infection. That does not appear to be the case.
Gotcha. All right, we have, oh, it looks like we're on our time. We have one more question. I'll have you answer in the chat, but we're gonna close up here, and I'm gonna say thank you, Dr. Soring, for your time, and thank you to everyone who joined us. And we hope you enjoy the next session that will be led by Dr. Arroyo.
Well, thank you. I'm going to stop sharing now and jump on for Dr. Arroyo.
Yes, take care, everyone.